So now I'll be going over the prognosis for acute respiratory distress syndrome and COVID-19. Some patient factors to consider that determine the contractability of ARDS in a COVID patient are increased age, male, obesity, history of smoking or blood type A. Also the presence of other comorbidities such as hypertension, cardiovascular disease, and diabetes can also determine. And the severity of hypoxemia, with the three standards of criteria being mild, moderate, and severe, will also determine how uh, severe the COVID-19 ARDS treatment is and the outcome. And the mortality rates for such are mild being 34.9%, moderate being 40.3%, and severe being 46.1%. Some other potential complications that could arise are secondary infections and organ dysfunctions due to COVID-19's unique systemic inflammatory vascular pathology. So some organ dysfunctions are acute cardiac injury, acute kidney injury, which will require renal replacement therapy, and septic shock, which is just a more severe sepsis. Cardiac complications, of course, such as mild pericarditis, ischemia, and arrhythmia. And 20% of these patients are usually on life-threatening ventricular fibrillation and cardiac arrest. 30% also suffer from neurological symptoms ranging from mild to severe, such as headache and dizziness. And autoimmune diseases can be triggered as well, such as Guillain-Barré syndrome. And there's also a bunch of possible long-term impairment of cognitive function, persistent pulmonary dysfunction, and prolonged neuromuscular dysfunction, which is a very common ICU-acquired weakness, and other swallowing disorders, dysphagia, which is also another common ICU-acquired weakness due to prolonged mechanical ventilation. And since COVID-19 ARDS has no specific medical therapy, prevention is key, so vaccination and all the steps beforehand, from initial onset, early recognition and treatment are key.